group. So that's the medication that was being studied, and not the bupivacaine that we normally use. So 55 minutes quicker resolution of the sensory block. And that chlorprocaine group also met discharge criteria 76 minutes faster than the bupivacaine group. Both medications provided similarly effective surgical anesthesia for cerclage placement, and both had similar times to motor block resolution, that number being about 109 and 112 minutes in the chlorprocaine and bupivacaine groups, respectively. The caveat being, it's still a new study, and they even said in their discussion that future studies would be needed to identify and compare equal potent doses of chlorprocaine and bupivacaine to confirm the superiority of chlorprocaine for this ambulatory obstetric procedure. So they would not, pronounce chlorprocaine as superior to bupivacaine for relatively shorter procedures. And there was even a second study done, and this study wanted to empirically show the optimal dosing of chlorprocaine in the spinal. So the first one compared it to the typically used bupivacaine, and this one just studied the right dose. And they showed that for, specifically prophylactic cervical cerclage, when using chlorprocaine only in the spinal, the median time to motor block resolution is 60 minutes, and the median time to sensory block resolution is 90 minutes. So, assuming the surgical procedure takes about 35 minutes, 20 minutes later in the recovery room, the patient will have resolution of motor function or of the motor block. And 90 minutes post spinal placement, the patient should have sensory back. So this could aid in quicker throughput for PACU discharge. Now, back to the question, is there a shorter acting spinal for quicker procedures? The answer is yes, but the medication that was studied was 3% chlorprocaine. And here's the label. This is, the same exact medication we have in our Pyxis. And right there underlined, it says not for spinal anesthesia. That being said, in anesthesia, a lot of things are used off-label, medications for nausea, medications for itching, medications even in the spinal can be used off-label. And, these studies somewhere along the line had been approved by review boards, but it still doesn't have the complete buy-in from the OB anesthesia community. So, and there are ambulatory surgical centers down in the South for non-obstetric procedures who are using chlorprocaine in their spinals for, orthopedic procedures, and patients are going home within a couple hours. So it is a viable option, but I think more needs to be studied. So, is there a shorter acting spinal for quicker procedures? Yes, but it's not fully approved by the FDA or accepted by the obstetric anesthesia community. That being said, studies are being done, and maybe there is a change in how long these patients are numb in the future. Okay, so next one, moving on. This one, we're going to address post-dural puncture headaches, everyone's headache, not just the patient. So Dr. Bhatt, my patient has a spinal headache. She said the anesthesia team tried 3 times for her epidural. What can we give the patient for her headache? So headaches in general are common postpartum. Some data show that the incidence is up to 39%. And of those, about 5% are usually spinal, epidural, or anesthesia related. There are 2 reasons a patient may have a spinal headache or a post-dural puncture headache. The first and more commonly is from an unintended dural puncture. So that's when placement of an epidural goes awry, the needle tip goes beyond the dura and creates a hole in the dura and allows leakage of CSF into the epidural space from the subarachnoid space. When this happens, about 80% of patients who receive a wet tap will develop a headache of some sort. Now, will that headache be severe enough to necessitate epidural blood patch or further treatment? Not always, but 80% of them will have some form of headache, neck ache, or, possibly cranial nerve symptoms. That's because we are using a cutting needle, a 17-gauge cutting needle. That's what the epidural needle is, the TUI needle. And it creates, a large hole in the dura that takes about a week to close on itself. Now, spinal, we are intentionally puncturing the dura to give medications intrathecally or subarachnoid. And depending on the needle size and type, it can be from 0.8 to 5% incidence of a post-dural puncture headache. The specific 25 gauge non-cutting needles that we use here at Robert Wood Johnson have been shown to about, be associated with 1% risk of post-dural puncture headache when doing a spinal. So this is just a, picture representation of what exactly we're talking about. So epidural anesthesia, as you see, goes into the epidural space highlighted by the lavender color here, and we place a needle, place a catheter there. However, that's a bigger needle that requires a catheter to go through the lumen of the needle. So when it punctures the dura, it creates a bigger hole, creates more leakage of CSF. And you can see below the spinal needle, much smaller needle with intended dural puncture. What are the risk factors for a post-dural puncture headache? So age less than 40 years old, female, lower BMI, pregnant, needle size and type, and number of attempts. So as you can see, the incidence in obstetrics is much higher than, the older arthritic patients getting spinals for their knee replacements, because most of our patients on labor and delivery will fit most of these criteria. But whenever working up a possible post-dural puncture headache, you want to consider, certain differentials such as migraine, caffeine withdrawal, hypertension or hypertensive disorder of pregnancy, such as preeclampsia, a pneumocephalus, which will have similar headache symptoms. However, it will still be positional, but it'll oppose the symptoms you would see in a post-dural puncture headache. So if the patient has a wet tap and has a headache, and all they can do is lie flat to get relief, that's a classic post-dural puncture headache. When they sit up, it's worse. However, if the patient has a pneumocephalus, which can happen when air is entered into the intrathecal space, if we're doing a technique using air instead of saline for the epidural procedure, the patient can have a pneumocephalus. That headache will occur immediately. It'll be worse when they're lying down, and it's relieved when they're sitting up. Some other differentials include lactation headache, subdural subarachnoid bleed. If we talk about the more ominous differentials, meningitis, stroke, Press syndrome, or cortical vein or venous sinus thrombosis. So again, we talked about how to identify, diagnose a post-dural puncture headache. Sometimes you'll have symptoms of nausea, vomiting, cranial nerve symptoms, tinnitus, stuffy ears, photophobia, diplopia. So what can we do for her headache? We talked about the headache. We've confirmed that the patient did have a wet tap. It was a difficult epidural, multiple attempts. And how can we treat it? So that brings us to this book. This is one of my favorite books, Controversies in Obstetric Anesthesia and Analgesia. As you know, it's difficult to do a lot of high power, prospective studies on obstetric patients. So, especially in the anesthesia and labor analgesia world, there's a lot of, common misconceptions, old myths, traditional ways of thinking that this book kind of set out to lay out the data and debunk things. So what is optimal therapy for a post-dural puncture headache? So conservative therapy and miscellaneous interventions. So we'll always say conservative therapy first. And I'll explain why we don't jump straight to an epidural blood patch. So treatment options include scheduled non-narcotic pain medications, acetaminophen, NSAIDs. I'm sure a lot of us have heard of Furoset. It's acetaminophen, caffeine, and butalbital, a barbiturate. Excedrin, which is acetaminophen, aspirin, and caffeine. And you can see a common theme being caffeine supplementation. Specifically on caffeine, it's been historically popular, but recently called into question its efficacy. IV and PO hydration, an abdominal binder to increase decrease the transmural pressure gradient between the CSF and epidural space, decrease the leakage of CSF, and sumatriptan, which is a cerebral vasoconstriction agent commonly used with migraines. And then lastly, you'll have more invasive interventions, such as your transnasal sphenopalatine ganglion block or your epidural blood patch, which is the definitive treatment. And what the epidural blood patch is just an epidural procedure where the patient's own blood is taken sterilely from a fresh venipuncture site and injected into the epidural space. And interestingly enough, the epidural blood patch procedure was discovered in 1960 in the setting of lumbar punctures because they noticed when patients bled during a lumbar puncture and they got a bloody tap, they actually had a lesser likelihood of a headache. So that's what warranted further investigation into why blood, for some reason, in the neuraxial space or in the epidural space, decreased the incidence of a headache. But importantly, and we'll show and prove why, the epidural blood patch within the first 24 hours of catheter removal is ineffective. And it's most effective after 48 hours from catheter removal or from delivery. So back to this sphenopalatine ganglion block. So it's a relatively benign in terms of risk profile procedure. That was actually, I don't know if anyone can see the small print here, first published by our own Dr. Cohen, along with Dr. Melander, Dr. Grubb, Dr. Kish, some names that I'm sure most of you may recognize. Published and reviewed as recently as 2019. And what it is just transnasal application of topical local anesthetic. This treatment has not been, shown to be completely effective in terms of the definitive treatment being the epidural blood patch, but it is a great temporizing measure. I think it's something that we should offer, we as in, my anesthesia colleagues, to every patient to either buy time as a temporizing measure until we've reached that 48-hour mark to where the blood patch will actually have the best chance of working. Or to what I often do is if I know the patient needs a blood patch and I know that is really the main thing that'll help their symptoms, then I'll give them the sphenopalatine ganglion block, with either drops of lidocaine down the nares or, pledgets with lidocaine on it, just kind of done like a COVID test, but staying there. Patients don't really like that, but it will temporize or mitigate the symptoms long enough for them to be able to sit up for me to perform the epidural blood patch procedure. So it's kind of full service. We'll treat the symptoms now while giving them the definitive treatment. It hasn't necessarily been, fully accepted in the obstetric anesthesia community as an alternative to an epidural blood patch. But it is a great remedy if it's a mild headache or if the patient wouldn't even be able to position without some relief prior to performing the epidural blood patch. It is commonly accepted in the neurology and pain management communities as a treatment for chronic migraines. Now, okay, back to what's new in obstetric anesthesia. So the blood patch isn't the be-all, end-all. It is our last resort and our best bet at treating and curing the post-dural puncture headache, but it can fail. So this study published in November of 2022 wanted to, tease out the factors that were associated with a failed epidural blood patch. Okay, so it was a large multi-center study, and it showed that the blood patch actually failed in 28.3% of cases. 33% of the blood patches were completely successful. A smaller percent were partially successful, but of everyone who received a blood patch in this study, almost 20%, so 19.8% needed a repeat blood patch. So why is that the case, and what can we do to better our practice to avoid subjecting patients to a repeat blood patch? Or what can we do to, do our best to ensure that the blood patch will not fail? So again, the study showed why blood patches fail. And the main things were the blood patch can fail due to performing the procedure too soon, within 48 hours. That being said, if the headache is so severe, I'm not going to make the patient wait another 24 hours if it's already been 24 hours. I'll do it then with the, complete you know, uh, providing informed consent that there is a possibility that we may need to repeat the blood patch, or if the patient has a history of migraine, so another underlying comorbidity that will predispose the patient to, a worse headache that may not necessarily be relieved with an epidural blood patch. So when we say we want to, we as the anesthesia team, just do conservative therapy, try caffeine, try hydration, try our non-narcotics, try our Fioricet, it's not because we don't want to perform the blood patch. It's mainly because we don't want to have to perform it twice by doing the first one too early. So, the blood patch is indicated, really only when the mother cannot, perform her activities of daily living, cannot care for the baby, the symptoms are too debilitating, and she's failed conservative therapy. So yeah, that was kind of conventional wisdom to not do the blood patch immediately. It's also been shown that a prophylactic epidural blood patch after getting a wet tap does not help because again, it's too early. And I think this is the reason why we do what we do in terms of waiting for optimal timing to perform the blood patch. Okay. All right, moving on. Next category, we'll be talking about thrombocytopenia, which is often, hotly contested and contentious in the obstetric anesthesia world. So, Dr. Bhatt, the patient in labor room, I can't see, the numbers are relevant, has a history of factor V Leiden, history of DVTs, she's on Lovenox at home, and is starting to get uncomfortable. Can she get an epidural? Well, so the patient's on Lovenox. So we'll talk quickly about anticoagulation guidelines. Again, in the past, this was very subjective in terms of the practitioner's preference or comfort with performing an epidural, a certain amount of time after cessation of anticoagulation and with or without repeat labs. So ASRA, the American Society of Regional Anesthesia, came up with their guidelines for coagulation and neuraxial. So specifically, the two most common ones we'll see will be heparin and Lovenox. So as you can see, with prophylactic dosing of heparin subcutaneously, you really only need to wait 4 to 6 hours. Prophylactic dose of Lovenox, 12 hours. Therapeutic doses of Lovenox, they're in the bottom right, 24 hours plus or minus an anti-factor 10A level, activated factor 10 level, which is an expensive lab test. It might be overkill as long as you've waited the appropriate amount of time. And then you can see with higher doses on the bottom left here with heparin, the time will vary based on the dose that the patient is receiving, and also repeat CBC and coagulation studies. Similarly, with infusion. And now an important thing here is there's no restriction for aspirin or NSAIDs. The aspirin, be it 81 or 162, daily is not a contraindication for neuraxial. There's no reason to wait because the patient took her aspirin this morning or last night. It's all okay for performing neuraxial. Oh, by the way, the next patient in room 3 has gestational thrombocytopenia. Her platelet count right now is 82,000. Can she also get an epidural? So this is the consensus statement released a few years ago by the Society for Obstetric Anesthesia Perinatology in conjunction with the American Society of Hematology, Society for Maternal Fetal Medicine, ACOG, and ASRA, this American Society of Regional Anesthesia. So this is the consensus statement that everyone has to rely on. This is our Shroud of Turin or our Rosetta Stone on what an actual acceptable platelet count is. Okay, and it's 70,000. It's lower than what I'm sure a lot of people thought, and even a lot of anesthesia practitioners who aren't too familiar with recent trends in obstetrics might be comfortable with. But they do say the risk for spinal epidural hematoma is likely to be very low, below a platelet count of 70,000. So the verbiage they use there, likely to be very low, doesn't instill that much confidence, but they do even mention that in the setting of gestational thrombocytopenia, immune thrombocytopenia or hypertensive disorders of pregnancy, it is still safe and acceptable to place an epidural or perform a spinal in a patient with a platelet count of 70,000 or greater. So for an otherwise healthy patient, assuming the trend of the platelet isn't, out of whack, it wasn't, double what it is yesterday than it is today, 70,000 is acceptable for neuraxial. Now, patients with comorbidities or a known hematologic disorder, the 70,000 threshold is a class 2A level C recommendation. So class 2A meaning that the benefits do outweigh the risks, but the data is conflicting. And level C evidence, so there are only observational studies, no prospective studies showing or justifying that number of 70,000. And this is kind of our algorithm for deciding whether or not neuraxial is acceptable or safe in a patient. Again, these guidelines are for otherwise healthy patients with, an isolated thrombocytopenia. And when they came up with this algorithm and these guidelines, they reviewed over 7,500 cases of spinal epidural hematomas, and the vast majority of them were in non-obstetric patients. Only 5 spinal epidural hematomas in this huge meta-analysis that they used to make these guidelines. Only 5 of those spinal epidural hematomas actually occurred in obstetrics. 2 had preeclampsia, 2 had HELP syndrome, and the 5th had a postpartum hemorrhage and DIC postpartum. And of those 5 epidural hematomas, 2 had a platelet count above the recommended 70,000, which is why some practitioners may still not feel comfortable with that number of 70,000. If in the study, 2 still spontaneously had a epidural hematoma. That being said, for all the masses, 70,000 is the number that is the consensus number given to us by our, I won't say governing bodies, but societies that kind of guide us. So that's placement of the epidural. Now, pulling the epidural catheter. If a postpartum hemorrhage or coagulopathy are suspected, the best practice is to leave the catheter in situ until laboratory confirmation of safe hematologic conditions. Pulling the catheter is a high bleeding risk procedure, similar to actually placement of the catheter, and shouldn't be done in a coagulopathic patient. That's why if there's ever concern for postpartum hemorrhage, to let the anesthesia team know, because in this institution, the nurses pull the epidural catheters, which we're very grateful for, but we would want to be involved if there's ever concern for a postpartum hemorrhage, just to make sure that catheter doesn't get pulled until we have laboratory confirmation of good hematologic conditions. Anticoagulation, again, can be restarted with a catheter in situ, but will have to be held prior to pulling the catheter. Okay, the last patient in room 4 has congenital hypofibrinogenemia. Hematology said epidural is contraindicated. And I think this is arguably the most important or interesting part of the talk today. Hematology said epidural is contraindicated. And I know this is a nightmare for you all as obstetricians on labor and delivery, because the patient's miserable. It may hamper or change or even dictate how you manage the patient, from an analgesic perspective. So a lot of times I'll be asked, is there anything else that the patient can get for pain, if an epidural is contraindication, if she cannot get an epidural? And the answer is yes, of course. The answer is always yes. But what are our options? So we'll go over alternative labor pain management techniques. So regional techniques we have on the left. Paracervical blocks, which has kind of fallen out of favor. They're very dangerous. I don't know anyone in our department who will perform a paracervical block anymore. It's often associated with fetal bradycardia, decreased uteroplacental perfusion. It's more, an answer choice on an exam than a real life clinical option. Pudendal block, is an option. It'll really only help with stage 2 of labor, and you still run the risk of intravascular injection and hematoma. So it may be a relatively contraindicated in the setting of a bleeding diathesis. But the erector spinae plane block, I bolded down there, that's something that it's been minimally described in the literature, just a few case studies that we'll go over. And it's something that, we've been able to provide to some of our own patients in-house here to relatively good effect as an alternative to neuraxial. But if the patient, can't or doesn't want, a needle at all, we have other adjuncts such as nitrous oxide, nalbuphine, which, is known as Nubain, IV PRN versus PCA narcotics. Remifentanil infusion or PCA, it's done at a lot of institutions, but not here. A lot of the hang-up has to do with monitoring the patient during the remifentanil infusion or PCA, because you need continuous pulse oximetry and ideally end-tidal carbon dioxide, because it's a highly potent risky medication, but it's rapidly metabolized and minimally transferred via the placenta. So specifically talking about the erector spinae plane block. So, this is just what the procedure looks like. As you can see on the left, they're doing it at about a T5 level. A few times I've done it for our labor patients, I generally go to about the T11, T10 level, just to get coverage on the dermatomes and nerve roots that will cover cervical contraction pain. On the right here is graphic representation of what the block actually is. So we have, we won't have the rhomboid or trapezius where we do it, but you'll have the erector spinae group of muscles, which just sit paramedian, paraspinal. Will identify the structures on ultrasound and place a needle right on top of the transverse process. So posterior to the transverse process, keeping it superficial, there's a fascial plane. That's your erector spinae plane. And injection of medication there, a large volume of medication, can provide good analgesia based on the nature of the block. So the way the block works is that you'll have absorption into the paravertebral and even the epidural space itself. And we'll go through some limitations and some benefits of this procedure. Anticoagulation is not necessarily a concern with this block. This block was initially made for major thoracic and cardiac surgery patients, and for cardiac surgery they'll get this block and then immediately get systemically heparinized to go on cardiopulmonary bypass. So there are no incidences of significant bleeding or especially no spinal epidural hematomas, no nerve compression. So it's relatively safe. It's not a closed compartment. If there were to be any bleeding, there's plenty of muscle and fat to where a hematoma could develop superficial to neural structures without causing any permanent neurologic damage. Okay, so this is one study out of Toronto. It was not necessarily a study. It was a 4-part case series of this novel technique. It was first published in 2020. So, only a few years old, still hasn't really caught on as widespread, but I think it's definitely worth offering it and performing it for patients because of the low risk profile and the potential for benefit. And I have had patients come to the labor and delivery floor with some bleeding disorder that prevented them from being able to safely receive an epidural or a spinal, and have had a delivery without any sort of regional anesthesia technique, and then had their subsequent delivery with the erector spinae plane block. So the patient serving as her own control, anecdotally and subjectively, said it was much better the second time around. That could be due to many factors, but I'll tell myself it's due to the erector spinae plane block. This study also showed that, interestingly enough, they even placed unilateral erector spinae catheters, which isn't done that often in this institution. And I still have some, reticence towards placing any type of catheter in a patient with a bleeding disorder, because like we said, pulling a catheter is just as risky as placing one. But it is something that, if this block for labor analgesia becomes more common practice, then placement of a catheter and being able to give them continuous analgesia would be a good option. This is another study out of Brazil from about 2021, 2022, that, showed bilateral ESP block provides adequate analgesia for just stage 1 of labor, can be an alternative analgesic technique for some patients with contraindications to conventional labor epidural. So when I offer these things to our patients, it's not just me being crazy. It's, described in the literature, and, can provide benefit with, next to no risk. So those are some good alternatives. Now, a little bit more about the ESP block itself in the last few minutes that we have. So again, it's a possible intervention for labor pain when an epidural is contraindication. The issue being is that the onset time is approximately 2 hours, and it's very variable because there are no actual nerves that we're bathing with the local anesthetic when we perform the block. It's really based on resorption of the local anesthetic and percolation through the paravertebral space. So it takes a long time to set up. It's ideally performed earlier in labor than an epidural would be. If we were to do an epidural or a continuous or a combined spinal epidural, it could set up, within 5 to 15 minutes, but this will still take about 2 hours. So proper counseling on our end from the anesthesia side of things is important in collaboration with the obstetrics team. If there's plans to start Pitocin in a little bit, or wait and see, to ideally give medication or perform the block earlier rather than as a rescue procedure, because then it'll just prove to be inadequate if the patient's already in severe pain. The duration of the block is, again, also very variable, approximately 6 hours, depending on the local anesthetic used. There's no contraindication in the setting of a coagulopathy, no documented maternal hypotension or fetal bradycardia, no lower extremity motor block, depending on the vertebral level. I generally do these in the lower thoracic level where it shouldn't drip down into the lumbar sympathetic plexus, but I still treat them as if they have an epidural and, encourage bed rest at that point in time. Supplemental medications will likely be necessary, but the point of the block is not to replace the epidural, but to provide something that will decrease their narcotic requirement, decrease any opioid consumption, because that's ultimately the goal during labor from the analgesia point of view. Larger prospective studies are needed to determine, optimal dosing and efficacy, and right now it's just anecdotal and, myself and our anesthesia teams just doing anything we can to provide some relief, because we essentially, when it comes to labor analgesia, feel powerless if we can't, place an epidural. So that brings us to the end of the presentation. I know we have about 20 minutes, and I can open up for questions or be happy to answer anything or clarify anything for anyone at this point.
Thank you so much, Dr. Bhatt, for an excellent presentation. Does anyone have any questions?
Hi, Dr. Bhatt. It's Haley Patrick from MFM. How are you?
Good. How are you?
Thank you for your talk. So I am excited about some of these alternatives and regional blocks that you're talking about. I can also say I served as my own control for the very nice spinal and tap block that you gave me with my repeat C-section. And I did not have a tap block for my first C-section because we weren't doing that a couple of years ago. And I am now the biggest tap block hype girl to all of our patients because I personally found a huge difference in my postoperative pain with the tap block. So I know that it's something we're already doing and maybe not so new in OB anesthesia, but I was wondering if you could comment a little bit on our experience with tap blocks and if you all are finding the same results with the other patients.
Yeah, so I think our institution and Dr. Rosen, Dr. Dunn, kind of spearheading the ERAS protocols for our C-section patients has been really helpful, really effective. Patients come back and they say the same thing. Their first C-section, they may have had some pain postoperatively, but the tap block with the subsequent C-section went a lot smoother. And I always try and follow up on these patients and see if they've received any postoperative narcotics. And it really has been helpful. It's something that we're going to start studying empirically, quantitatively, compiling data showing the difference in opioid consumption. But without depriving any other patients of tap blocks. In the obstetric anesthesia literature, they initially did describe tap blocks with just plain local anesthetic, which will resorb and stop working after about 6 to 8 hours if they used ropivacaine, which is what they initially studied. I think the benefit, and again, no financial disclosures or conflicts of interest. I think the benefit to the tap blocks that we're doing here are with the liposomal bupivacaine with the Exparel. Its ability to last, that 48 to 72 hours means it outlasts the Duramorph that we're still giving in the spinal. And the main thing in terms of enhanced recovery that we've been doing is decreasing the amount of Duramorph that we're giving, because I see Duramorph as it's not the ideal medication. There's high incidence of postoperative neuraxial induced pruritus, high incidence of postoperative nausea, vomiting due to the intrathecal morphine or epidural morphine, the Duramorph. So in decreasing the amount of Duramorph we're giving, we decrease the side effects, but without sacrificing analgesic control, we're still providing them with the tap blocks for somatic analgesia for coverage of the incisional site. So I think it's been really good. I follow up on these patients. Very rarely will they need, their oxycodone 5, and I see those orders aren't even being placed reflexively anymore. They're kind of, as an ask and as needed basis, which I think is great. And I don't know if you all on the obstetric sides of things see this as well with opioid consumption, but I think it's something that there are a lot of opportunities for studying in the future. But anecdotally, it's been great. The patients, I agree, do really like it.
Dr. Sharma's hand is up.
Well, thank you, Dr. Bhatt. This is Ruchira from again. Thank you for tackling the controversies head on. The one question I have, which is something I was surprised about, you said for post-dural puncture headache, being female is a risk factor. Why would that be? Is it because it's something specific about the anatomy or maybe dimensions of the space?
Yes. So that's a good question. I had the same questions. I couldn't find any physiologic rationale for it, but I think it's an issue where possibly in the initial studies, they considered correlation equaling causation, in that probably the majority of patients receiving neuraxial are obstetric patients. So there's just more data on post-dural puncture headaches in the obstetric population. So, I mean, again, this is just me speaking subjectively. Possibly they're just looking at the numbers and saying, oh, more women are having headaches, but I think it's just because the prevalence of patients receiving neuraxial is, more women than men. But again, I don't have a good answer for that in terms of, the science behind why it's women over men in terms of likelihood of a post-dural puncture headache.
Thank you. And the other question I had was, if you heard the second M&M case, that patient was sort of going into DIC, bleeding, although her hemodynamic parameters were kind of normal at that time, right? Fibrinogen was 300 plus, platelet count was, I think, normal. But what is your take on, should we be having, in those cases, the point of care devices like Rotem or TEG, or those are the things we should rely on more, or would you still feel comfortable? Like in her case, neuraxial was denied, right? Because of obviously your conventional lab tests are probably lagging behind. So just your take on that.
Yeah, so that's an amazing question. I'm really happy you brought that up. So we had a patient recently. It wasn't emergent like this. It's just a history of a bleeding disorder. that, they were consulting us for possibility of neuraxial while the patient was here in labor. So what we have in terms of point of care viscoelastic monitoring, our TEGs or ROTEMs, is this institution primarily uses ROTEM in the cardiac surgery arena, and they run those ROTEMs, the perfusionist will run it right there in the cardiac ORs. It's not necessarily readily or widely available for any other patient populations, except for another test called an XTEM, which is a similar, rotational thromboelastic measurement that, I sent an XTEM on this patient. The lab can run it. It takes about, 30 minutes to run and get the results. And, despite this patient having, thrombocytopenia or, a factor deficiency, if they proved on this viscoelastic test that there was no increased bleeding tendency, then, I deemed her, safe to receive an epidural. She got an epidural, no neurologic deficits, and everything worked out okay. And actually, one of the one of the most widely appreciated case reports at the SOAP annual meeting last year was exactly that. Patients with, I think it was a patient with congenital afibrinogenemia, where they did a combination of fibrinogen replacement and serial ROTEMs to guide their management. And they did a combined spinal epidural for labor for that patient. And, everything worked out okay, despite, fibrinogen levels sub 100 to start, and their goal being 200 or 250, if I recall correctly, to place, a neuraxial block. So I think that's definitely something that we can, look to the future to, maybe even getting a point of care machine on the labor and delivery floor, or just having ready access and lab capabilities to run these exams. We do have it, but I think a lot of the onus is on, myself and our anesthesia colleagues to advocate for sending these tests to do everything we can to, offer these patients neuraxial safely.
Thank you so much for that answer. And that came up to my mind because I was, as a MFM fellow in New York, we were part of an industry funded study where we kind of did the similar kind of case series for patients who would not otherwise be offered conventional neuraxial. And we had that point of care device where we would do, the TEG or ROTEM. Actually, it was both TEG and ROTEM because they were comparing between TEG and ROTEM. And then they would send the XTEM and FIBTEM as well. And we clearly found a benefit. All those patients could get actually a neuraxial because of that. So I agree with what you said. Thank you.
Thank you. Also, in addition to that, the machine is not just for placing epidurals, for also guiding transfusion management during a postpartum hemorrhage, deciding which products the patient actually needs. It's important for that as well. It can be helpful.
Absolutely. Yeah.
Go ahead, Dr. Montero.
Hi, good morning. Thank you for this great talk. So I just had a question again about the TAPS block, because I think we've all seen great outcomes, both obstetrically and after our hysterectomies. Unfortunately, not all of the anesthesiologists do TAPS blocks. So is there anything happening on your side where you're trying to train the providers that don't do TAPS blocks to feel more comfortable? Because there's sometimes at 3 a.m. when the provider that's on doesn't do the procedure.
Absolutely. This is, a situation I've encountered many a time when coming in the morning and hearing a patient's been sitting in L&D PACU for 3 hours and hasn't gotten a tap block. We are in servicing. I think there's about 2 call-taking attendings who work, in-house overnight that don't feel comfortable performing the taps, and it's a very, very easy procedure. And, all the residents are trained in it as well to kind of guide if needed, but some of the attendings just don't feel comfortable. So a lot of it is working with these attendings, giving them an ultrasound crash course. And that is something we have planned for later on early spring, to have like an ultrasound demonstration and kind of workshop with those few attendings and anyone else who wants to refresh their skills as well. So that's a great point, and that is one of the hurdles that I'm working on right now.
Great. Thank you. And my second point is, because we work so well collaboratively, our department and anesthesia, this month we'll be starting team birth, which is, the OB providers, the nursing staff, the residents. And I think we should get anesthesia involved. Like, we'll be rounding on patients, especially in a difficult patient. So somebody, not that we use ESP blocks like you mentioned, because it takes so long, but if there's a patient who has low platelets or has an issue that maybe we could initiate a block sooner because it takes longer to kick in. So I think it would be important to have anesthesia as part of this OB team birth concept that we're starting this month.
Absolutely, absolutely. And I think, admittedly, a lot of the, again, the onus is on our team for, being proactive and being there for the board rounds, with nursing and obstetrics now. I think that's definitely an area for improvement. And, I think that initiative, this collaborative initiative is very important for everyone to be on the same page about the patients and not it be a game of telephone from the obstetrician to the OB anesthesia resident back to the anesthesia attending, and things getting missed or lost. But yeah, absolutely, I look forward to that.
Great, thank you.
If you're speaking.
Michelle, are there any more questions?
Oh, hey, Dr. Rosen, it's Danny. I have my hand up if no one else does.
Go for it.
Hey, Dr. Bhatt, this is Danny, one of the residents. Thanks for an awesome talk. So my question is kind of along the lines of Dr. Montero, in terms of like trying to standardize the protocol for what we can offer our patients. I feel like anecdotally, there are different attendings who have different comfortabilities in terms of the platelet levels when it comes to offering an epidural, or even a patient who is not a candidate and has plans to get an ESP that was discussed with you or one of your colleagues kind of in the antepartum period. In reality, when they come to labor and delivery, I've seen it where the attending who's on doesn't feel comfortable doing the ESP or think that the ESP is not appropriate for the type of pain that she will be feeling, and so kind of dissuades the patient from getting it. Can you think of maybe like a better protocol that we can start to do, or something that can become more standardized to make sure that we kind of remove the bias of attendings having different thoughts or clinical experience in terms of what we can offer our patients, especially if what they're kind of told in the antepartum period, to make sure that it matches what's actually being done on labor and delivery?
Yeah, no, that's a great point, and I understand and empathize with your frustration from, our very own interdepartmental variability and subjectivity. We've been trying to cut down on those middle of the night question marks and failed promises by, optimizing the labor consults. And whenever I see a labor consult and it's a scheduled case, if I'm not there personally, I'll try and reach out to the attending who will be, on labor and delivery that day. But in terms of overnight, that's tough because, we're an institution that only has one anesthesia attending in-house who isn't necessarily, always comfortable with everything that, I propose as a plan for the obstetric patients. In terms of writing protocols, I think that's a great idea. But it would have to be individualized to every patient, and that's kind of where the labor consult note comes in. And I think I tell my department my phone's on 24/7, for calls in the middle of the night about questions like this, and I'm more than receptive to it. But a lot of the problem that I know you all see and that I have is, you can't. For lack of a better term, you can't force someone to do something. But by providing, appropriate data and proper training, I think we can hopefully try and cut down on those lapses in, patient care plans in the future. So I know it was kind of like a politician answer, but I hear you and I feel you, and we're doing our best to kind of standardize things and for lack of a better term, get everyone on board.
Thank you so much, Dr. Bhatt. Any other questions? Okay, well, we will just end early here. Thank you so much for giving an excellent presentation, and I hope everyone has a great day.
Thank you. Thank you everyone for having me.